Great. Tēnā koutou katoa. Welcome to the Bioethics Centre seminar. I'm Mike King, Head of Department, and it's my pleasure to introduce Janine Winters, who's going to be, who's a staff member here and is also a palliative care doctor. And so she sits in between doing academic bioethics and clinical medicine, particularly within one of the most complicated areas of medicine, and one that's seen some change over recent times too, which certainly puts it squarely in the middle of bioethical progress in New Zealand. So I'm going to hand it over to Janine, who will be speaking to you. We'll have about half an hour of talking and then half an hour of questions. Yeah, great. Over to you, Janine.
Kia ora, tēnā koutou katoa, ko iri te roho, ko kaihoga te manga, ko Janine Winters, toko ingoa, tēnā koutou, tēnā koutou, tēnā koutou katoa. So I'm going to talk about things that have shaped my worldview in treating complex and unusual situations in medicine. And hopefully you read the abstract, but basically there's three topics that I'm going to talk about: complexity, time, and decision-making. And I did switch the orders of this at one point, so it'll be in a different order. So this is something I've learned since I've been here in New Zealand. And it really was an aha moment about where things go wrong when trying to deal with an ethical dilemma in clinical ethics. This is a framework from business that I'm going to talk about, but I'll tell you about a case first. So this was a 6-year-old boy who was diagnosed with cancer. This is actually a true case out of Australia that there's some references for down there at the bottom. After the first round of chemotherapy, the parents informed the oncology team that they decided to withdraw from chemotherapy and radiotherapy and curative-focused treatment. And then there became a win-lose binary situation between the families and the healthcare providers, and conversation broke down. And then there's also an importance of urgency, because time is a factor. The longer goes by without treatment, the less likely that there is for a cure. And the oncology team brings the question, calls out for help first for some ethical guidelines, and then eventually to the courts. So what I think about here is that you can classify this situation as, you say it's simple. Well, there's a chance for a cure. The parents don't have the right to withhold a chance for a cure from the child. We want to act in the best interest of the child. But this situation might be really complicated. And so some of the questions to ask, do the parents have the prerogative to withdraw curative-focused treatments? If they don't, what measures are justifiable to force the parents to comply with the recommended treatment? And what would you want to know to make a recommendation? Say you're on the committee or you're going to take this for a court. So my aha moment is the first thing is to figure out how complex the situation is. So the 4 quadrants are there. I'm going to go through it. The first one was actually on the last slide, which was simple. A simple one is where you can have a best practice that you can look into it, use your senses to see what the situation is, categorize it, and respond to it. When you get to complicated, there's more than one answer. And so cause and effect does have a relationship, but it's not necessarily self-evident, and an expert can really be helpful to you. And I'm going to say to you that I think a lot of the things going on in medicine are in the complicated, which is one of the reasons we have lots of experts within clinical medicine. The next one is complex, which is emergent practice, that you try different things and you see what happens because nobody knows what the right answer is going to be. And cause and effect are only obvious in hindsight. And then finally, you have chaotic, which is anything can happen. And importantly, that if you miscategorize something as simple, you can fall off the cliff there into chaotic. They call that the zone of complacency in this model. So this is Janine's representation of the two. On the bottom, you have something that happens all the time. You get a little bit of a tangle up of your cord situation, but anybody can get it fixed. When you get complicated, you really kind of want an expert to fix your electrical problem there. And then complex, you've got your thing of spaghetti and you aren't really sure if you tug on one, where the other end is going to be. And then chaotic just is on fire to me. And there's the danger zone between obvious and chaotic. So where does that leave us with this case? I think that if this case gets categorized as simple, oh yeah, we know there's one right thing to do, we know what that is, and we're going to do it, that you get into trouble. And I'm not saying actually the judge did this. I'll describe what happened. And it did get into a lot of trouble, but the judge was acting to buy more time initially. So the 6-year-old, there was a ruling in family court that the boy should undergo chemotherapy, and they did. And the parents put in the box down there, they put a forced chemotherapy sign over his bed and refused to help the treatment team to comfort him when he became upset. And there's in more detail, there was a lot of trouble with his pain management because the parents were not cooperating with the team and the child was sensing how upset that they were. The parents had talked about leaving the country to escape from forced treatment, and their passports were being held. Wrong way. And so it became, very high stakes with a lot of questions. One of the questions is why did the parents refuse treatment? And I think it matters. The narrative to me, Grant and I talk a lot about narrative medicine, and the narrative matters. The healthcare providers, and one point of view is that she wanted natural medicines. But another thing that they also said was that they were worried about his quality of life, the impact on the family, as well as their wish to try alternative therapies. And they had gone through a first round of treatment, and they thought that it was cruel to put him through this. They thought that there was an invasive treatment, and that overall in the box down there at the bottom, 50 to 60% chance of survival after 5 years, 30% with chemotherapy alone, and that the numbers were changing every day while they were having a dispute. And so the judge, and I respect the way they put that in the biggest box at the end, saying that this decision isn't just about medical care. It's about social, moral, and ethical issues in which the answer is inevitably affected by the personal perceptions of current social conditions, standards, and demands. And then how do you balance all of those to reach a practical conclusion in the best interest of the child who's at the center of the dispute? And so I think that in medicine that we want things to be simple, and you have to sometimes simplify things to continue on in life. Last 2 weeks ago now, I was working with the medical students about informed consent, and both of the groups said, why 16? If they're 15 and 9 months, don't they have the same decision making as a 16-year-old? You know, how come they take away the decision making powers of people who are 15 and a half? And my answer was, because you have to pick a number in between, you know, birth and adulthood. At some point, most children are able to start making their own decisions. And if we assessed each one individually and tried to assess it, you know, 2 or 3 times to get inter-assessor variation relief, you'd spend all of your time assessing adolescents. And so we do try to simplify some things for very good reasons. But there's not a protocol for everything. And I think that some of the current moves in medicines to try and say that there is a protocol. And one of my examples, most of you know I'm a palliative medicine doctor, and we see quite a few patients come into us with some horrific short prognosis illness, but they had a recent cholesterol drawn. And so we're like, well, everything else is like not doing really well, but their cholesterol is great. And what we're saying is, why did we measure the cholesterol? Well, it was on the protocol. You know, the doctors are getting incentivized to make sure that they check that cholesterol every so often, because it's part of the well screening. And those protocols probably help a lot of people, but you've got to be careful that you don't ding people who aren't following them for very good reasons. Okay. So topic 2. I had an aha moment when I was thinking about do everything. And how do I conceptualize what do everything means? And I'll give you a case in a minute. And I now say the second thing on that list very frequently, which is that I make 2 hands and say it's marrying values with what is medically possible. And I'll describe how I came to that. So case, we will take the risk. So a neonate was born at term at Regional Medical Center, but was critically ill, and he'd aspirated meconium. And there was a discussion about whether the parents would want transferred to big city hospital for a very invasive and often tentative therapy of ECMO, which is oxygenating the blood outside of the body. Very few machines, very difficult treatment. The transfer to big city hospital would require 7 hours, 2 ambulance transfers, refueling stop for the aircraft. There was unpredictable weather that day. It was worse than usual. The parents would have to travel separately on a commercial flight. And so the neonatologists had a conversation at Regional Medical Center with Big City Hospital, and they decided not to offer transfer due to the risks of the intubated neonate, to resource limitation, and concern that death in the aircraft away from the parents would be the worst outcome of all. And the parents disagreed, and they disagreed strongly, and they said, we will take this risk. I think it was phrased to them that the neonatologist said it was too risky. And I said, oh, we take responsibility for this risk. We want everything done. And the question is what to do with that. I will mention too that the intubation was a key factor here, that those tubes get dislodged every time that there's a chance of it every time that somebody is moved with that. So all of those transfers in and out of ambulance and so on, each time that tube could get dislodged. So what do I mean do everything really means do everything helpful? I actually think that we should try to correct, if we can do it gently, that saying. It's become like a meme in society, do everything, along with fight. And so that we talk, oopsie, went the wrong way. That's why that slide's repeated. Okay. And that's where we get into trouble. who gets the final say is still up in the air. I think it depends on all of the factors. Most of the time, I think that, especially here in New Zealand, the doctors, the medical people get the final say. Though certainly the parental preferences make a big difference, but it brings up such big questions about what is harm and what is futility. I defined futility as I understand it, which is that the benefits are unlikely, very unlikely, to happen and to meet the goals of care. So the goals of care are unlikely to be met. So I think this case with the neonate is that the goals of care of having a healthy live infant at the end of this were unlikely to be met. But the focus became about the disagreement around taking the flight to Auckland. That then brings me into what's the burden on the surrogate decision makers. I've actually seen in the US where the treatment team will do something they think is futile and sometimes even harmful, because they say, I want the parents to be able to sleep at night knowing that we did everything. And I even heard this in a grand rounds, in a morbidity and mortality conference, that the speaker told everybody in the room about how this is why, why did you do this? Well, we wanted the parents to be able to sleep at night. Vulnerability and expertise. I guess another aha thing I've come across, and I don't even know when I had this, is that everybody, we are all vulnerable at certain times in our illnesses. Parents are vulnerable when you have to make a sudden decision very quickly in these most difficult of circumstances. That vulnerable people are not a fixed group, that they're a group that we all pass through at times. Okay. And then finally, this gets on to what are the limitations? What is the purpose of doctors? And I think that the purpose of doctors is not obsolete in my last statement there, that it is a second layer of judgment when someone is in a vulnerable position or making high stakes decisions. And I tell you that was a journey. I think this was a slow journey more than an aha moment, because when I started where the medical students were the other day, when we were talking about informed consent, I was very much as they were. Why are these paternalistic older people telling 15-and-a-half-year-olds what to do? And as I've traversed seeing all the things that happen in medicine, I have become an advocate for soft paternalism, of trying to share moral burdens with families who are making extremely difficult decisions and have to live with themselves after they make those decisions. This final thing is one other thought on the who makes the decision, is outliers being overrepresented in social media. So this family that we just spoke about found a prematurity group. They said that they should insist on ECMO, that they should fight, and that they weren't even good parents if they didn't fight. And I've given this a lot of thought about how parents who are outliers, whose children have done better than expected and are still alive a long time later, tend to get clustered on social media, and that it increases this vulnerability. But it's quite interesting, who makes the decisions. Certainly a generation ago, we were never thinking about third parties that were out there, but it's become a part of clinical medicine today that became really evident during COVID. Yeah, and these are just some of the types of these are real situations that I've had about social media encouraging people to fight for their child. You have nothing to lose, or you're a bad parent. All right, let's get that. So the summary, I think I've done pretty well, is that looking at, I think that the principle-based ethics helps. I think that virtue-based ethics also helps, and I think narrative ethics all help in this situation, but it's still a difficult one where autonomy and non-maleficence will become in conflict. All right, this is my third and last topic. And this one was even more of an aha, I'd say, than the middle one was maybe more of a slide into different thinking. But this is about time perception. And I've really given a lot of thought to this in the last about 15 years now, where I read an article that led me to a video that led me to a bunch of books and a change in my perspective. So in pediatric palliative care, we're told that our job is to think ahead. And I'll show you that in a second. But the doctors and the patients can be way out of sync here. And we ask in green, what do parents want? You know, we're teaching our medical students to ask that question. What do you want to know? But I haven't heard very many people talk about and dissect when do they want to know it. And I've come to believe that that is as important as what do they want to know. So my dilemma is that it's an explicit part of palliative medicine, and I put some of the guidelines here for you, is to anticipate the future needs of the patient, thus reducing the distress caused by not having the correct medicines readily available. And they tell you to ensure that you have everything in place for them, that you've thought about the symptoms, that the education is all in place, the equipment is all in place. Well, it's really hard to do that if you've got a family that is in the state, oh, I don't want to think about it, or in a defense mechanism or denial, well, I don't need to think about this because this is not really happening right now. So this started with an article, two articles and two videos. Zimbardo and Levine are the two of them. And this is my summary of what I learned from Zimbardo. But I was going to try and summarize Zimbardo, but I've already got a video that's a summary. So we're going to listen to 5 minutes of the video because I couldn't do it any shorter than what he did. But many of life's puzzles can be solved simply by understanding our own time perspective and that of others. Lots of conflicts we have is really a difference in time perspectives. And once you are aware of that, you stop making negative attributions. And I did absolutely find myself making negative attributions towards those families that wouldn't go with me to put, the things in place that their child needed in their home, the medicines that they needed. I was so frustrated. This is my job and you're going to need this. Why won't you do it? And it's really difficult. So can we make sure the volume's all the way up?
And you'll need to make sure the screen sharing stuff, share sound.
Screen sharing.
Okay, this is embedded in my video, in my presentation. It's not a link, is that?
Yeah, but when you go screen share, you need to tick the box that says share sound. So
okay.
So you might need to reshare your screen, maybe.
You could ask if anyone heard it. Scenes online.
People online, can you tell me if you can? And can you hear it? You can't hear them.
No.
No. Okay,
So
right.
you go stop share.
We're gonna have to try something else.
But when you go share again, go share screen, and then so you share sound
There on the bottom. Yeah.
product.
Yeah,
Like the
great. Very good.
Years of research, there's 6 main time zones that people live in. 2 focus on the past, 2 on the present, and 2 on the future. The people who focus on the past either remember all the good old times, successes, happy birthdays, nostalgia. These are the people who keep the family record, the family books, who have the family rituals. There are other people who focus only on regret, only on failure, only on all the things that went wrong. So we call those focus past positive or past negative. There are 2 ways to be present-oriented. The most obvious is to be hedonistic, that you live for pleasure and you avoid pain. You seek novelty, you seek sensation. There are other people who are present-oriented because they say, it doesn't pay to plan. My life is fated. Fated by my religion, fated by my poverty, fated by the conditions that I'm living under. Most of us are here because we are future-oriented, that we have learned to work rather than play, to resist temptation. But there's another way to be future-oriented. Depending on your religion, life begins after the death of the mortal body. To be future-oriented, you have to trust that when you make a decision about the future, it's going to carry out. If you have great inflation, you don't put money in a bank because you can't trust the future. If there's instability in your family, adults can't keep their promises to you. The closer you are to the equator, the more present-oriented you are. The more you're in an environment where climate doesn't change, it gives you a set of imagining sameness rather than change. Protestants everywhere have higher gross national product than Catholic countries, in part because of the Protestant ethic, because of the notion that you work hard to succeed, to demonstrate that you are God's chosen people. My family comes from Sicily, and in Italy there is a political movement called La Liga to cut Italy in half, to have North Italy and South Italy, cut it just below Tuscany. The people in the North say, we do all the work. The people in the South are lazy. They're like children. They want to have babies, have 3-hour dinners, etc. People in the South say, they're not Italian, they're German and Austrian. You know. They eat yogurt instead of pasta. They take their lunch in a paper bag. And in the recent election, the Liga got 14% of the national vote. It turns out it is accurate. We've done research to say people in the North tend to be, on a scale, much more future-oriented. People in the South tend to be more past-oriented or present hedonistic. And so my family is Sicilian, and I come from Sicily. I go back every year. I started an educational foundation. We send high school kids to college and set up computer labs. And I'm talking about some of this stuff, and a man comes up and says, I'm a poet. I live with words. And it wasn't until I heard you talk that I realized there's no future tense verb in Sicilian dialect. I said, what do you mean? There was, is, there's no will be. He said, that's why nothing gets done. And I didn't realize it because we never plan. So again, here's how when you have a number of people who share a certain time perspective, then it does come to characterize the nation. In the same way, if you have a Catholic nation where people tend to be present or past-oriented, rather than a Protestant nation where in general people tend to be more future-oriented, it affects you in very profound ways. So there's a wonderful book called The Geography of Time, and it's written by a dear friend of mine, Robert Levine, who's a social psychologist, and he actually literally went around the world doing wonderful experiments. He looks at what he calls the pace of life. See, time perspective is how people divide their own experience into partitions, time zones. Another kind of time orientation is your sense of duration. How much time has expired while you're sitting in a dentist's office before they start drilling? How much time has expired when you've been waiting in line? How much time has expired when you're having fun or at sex? So time duration is totally a function of whether you're bored, whether you're excited or not. And what he does is he shows that in different cultures, people have a different pace of life. And you do this very simply. You sit in a cafe and you mark off 100 meters, and as people pass, you start a stopwatch. And you see how fast people walk. You go to a post office, and on a piece of paper you say, I'd like, 3 pounds of this postage or 10 euros, and you see how long it takes. So he has a bunch of these measures, and it turns out you can identify cultures as different pace of life, and now cities. And he shows in America, you can rank 60 cities according high pace of life and low pace of life. And the ones that have the highest pace of life, men have the most coronary problems. That is, this becomes part of your whole way of life. We all begin life as present hedonists. All of us. I mean, at the breast, at the bottle, we want pleasure, we want to avoid pain. And one of the things that families do, and especially schools,
people thinking about the future. That's where he's going with that. I skipped a whole bunch in the middle. I don't agree with every single thing he says about Catholic versus Protestant countries and stuff, but it's what started the conversation and got me thinking. And this bit too, I decided to.
all addictions are addictions of present hedonism. Food, sex, drugs, gambling, etc. All of our propaganda, all of our educational message, all our public relations messages are designed for future-oriented kids, who's not the problem. They tell you, here's the negative consequences of doing what you're doing. Future-oriented kids know that, and they don't do it. Present-oriented kids know the future consequences. If you're a teenage girl, you know that if you have unprotected sex, you're likely to get pregnant or have sexually transmitted disease. You know it, but that knowledge never feeds back to change your behavior. So that's the interesting thing about time perspective.
And then finally, this is his conclusion.
Many of life's puzzles can be solved by simply understanding our own time perspective and that of others. Lots of conflict we have with people is really a conflict in different time perspectives. Once you're aware of that, you stop making negative attributions like you're dumb or you're childish or you're pig-headed or you're authoritarian. It's really the most simple idea in the world.
So when I think about time, I mean, he was talking a lot about the Western cultures, you know, with European and Catholic and Protestant and stuff like that. But when you broaden that even more, when I went to Australia a couple of years ago, I was really interested in the perceptions of time. And I know that there's a lot of cultures that think of time circularly, but trying to apply in medicine when a culture has a circular thought about time, and you don't even know where your individual sits within that culture because every individual is within, you know, a spectrum themselves, that it's, you know, we think of time as simple, but it's actually, we miscategorize it back to categorizing things as simple, as complicated, and the perception of time is very complicated. So my main 3 points were assessing and communicating the complexity of a medical decision, recognizing and understanding cultural differences in time and planning ahead, and what happens when, you know, your patients don't actually tell you this, it's their actions more than their words that makes this distinction, and approaching tensions between autonomy, maleficence, and the role of third parties in that. So my final thoughts were to think about in New Zealand what supports clinicians and patients in communication. What supports are available? I'm really on a roll here to advocate for more clinical ethics supports, because these conflicts, these dilemmas, they come up, and it's taken me, I've been in medicine 33 years now, and you don't learn it all at once, even when you want to learn it. And so how can you take the brains of many people and apply some of this wisdom when you need it, where you need it? And then broadening outside of healthcare providers to the people who regulate, to oversee, and fund healthcare, that these, especially misassigning complexity, is really important. If you want to have protocols and people following the same thing, you know, every time, and saying that it's, oh yeah, you got to do this every time, you're going to end up with cases like my lovely patient whose cholesterol is great, despite the fact that they're within a week of the end of life, and we've just measured their cholesterol. So that's what I have to say, and I'm ready for discussion and questions.
Okay, so questions, hands up virtually online, and hands up in the room too, and we'll cycle around. No questions online? So, Grant.
This was a great talk. Thanks, Janine. I'm driven back to a moment in my 6th year as a trainee intern when you do 3-month rotations in Auckland on different specialties. And I was on pediatrics, coming at it from an orientation towards neurosurgery and therefore very hooked in to an intensive care mindset. And we had a child there that was dying, but a long, slow death of incipient failure of the renal arteries. And you kept that child's measurements within sustainable physiological limits by obsessive attention to testing and manipulation of physiological variables. And as a 6th year learning my techniques of clinical care techniques, I became obsessed. On my 3 months in pediatrics, I would visit that child every day and more than once a day and keep those measurements and things as strictly as I could within the limits. And the child was, in a sense, going through agony, but unable to show it, and the parents were kind of going along with me as the caregiver who'd been close to them and was apparently following the agenda that they in their mind had idealized in an unrealistic way. So for 3 months, we kept that child relatively normal. And then I moved to another run, as one does in 6th year, called back a couple of weeks later, and to the relief of everybody, the child had died. Now, what does one take out of that? That the caregivers weren't as fastidious? No. A bit of cool reflection revealed to me that the caregivers had finally realized what our intensive clinical care had constructed, that had trapped the parents and the child in. And as long as I was obsessively following that regime, nothing was going to change. But when I moved, compassion and humanity took over, and I think natural goodness prevailed much, as you've talked about. Sorry, it's not really a question, but I thought it was kind of supplementary to you.
Yeah, question.
Thanks, Janine. That was great. Very stimulating talk. I had a suggestion, but also a question about time. Look, there's something really interesting in the Zimbabwe stuff and about how time is culturally specific in different traditions. But I was thinking that even within us as agents, one of the things, and I wonder about with some of these cases with things in court, is when the pressure really comes on a healthcare professional, the sense of this thing must be dealt with now can come on, and I wonder whether that can be the thing that doesn't enable patients to be told things at the right time. So that was the question about this. I was kind of curious to know what you're thinking about doing with all of this, because I could see you developing these and putting these ideas into a book that's about clinical ethics that has a distinctive approach to clinical ethics.
Thank you. I haven't thought about a book and what to do with it. We should talk more about it. Yeah, it's something that I wanted to show to this group because I've mentioned these ideas to a few people over time, and I continue to wrestle with it. Not everything in Zimbardo or Levine, is exactly on, I think, but it's something there that I think that clinicians and ethicists have to learn from, and that without thinking about it, we have a blind spot. And it was my blind spot at one point in time that I really try to not have as a blind spot now.
Any other questions?
A suggestion for your book, which I think is a very good idea. Ethics with the smell of the clinic. With the smell of the clinic is something that a colleague in psychiatry years ago at a meeting in Leicester in England said to me, what you bring to the philosophy of psychiatry, even though you're not a psychiatrist, is the smell of the clinic. Never stop.
I really find a lot of value in the psychology, in these guys are psychologists, and in the moral psychologists. I find I have a background in that from long ago, but I find it very useful in considering problems.
Janine, are you aware of other, these sort of ideas that you discussed with other doctors? Do they share these sorts of ideas, or do they have different perspectives on this?
Yes, I've shared them with other doctors. I think generally speaking, most of them are like, oh yeah, that's really interesting, and then we don't talk about it again. So I don't know how many people I've really influenced. It seems to be for some of them, oh yeah, that aha moment, like, yep, I can see that, but I don't know what we all do about it.
Yeah, that seems to be.
And John's point is relevant here, in that sometimes there isn't a time choice. In my work in pediatric palliative care, some of the conditions that we were talking about were not didn't require an immediate sense of time, but we'd get there would become the big anger with the clinicians told the parents 2 and 3 and 4 times about a terminal diagnosis, and each time it's like the first time and the parents say no. And then there's the anger the other way, where the parents are like, no, I understand perfectly well that my child has a terminal diagnosis, but I don't want to talk about it right now. I can't live in that moment all of the time, and I really wish that you'd stop telling me over and over again because I don't look sad enough for you. And those kinds of things make a lot of tension that people, it takes a lot of experience to become aware and to think if you can differentiate between those two parents that don't, between the parent that doesn't really understand and the parent that does but just can't live in their sad place.
Ben.
Yeah, hi, great talk, Janine. And as you know, the bit about complexity is one of my enthusiasms, and those of you who've been around for a while might have seen the presentation I did actually with Dave Snowden some years back. I include it in my lecture on evidence for the medical students. I think it's a central idea that we have to all grasp, because I think a lot of the problems we get into is when we are dealing with a complex problem that's actually being treated as either simple or complicated. So I mean, I think it's a really, really important concept that we just have to include in what we do.
So I should have attributed, I first learned about this concept at bioethics seminars and from Ben. So that's how this came into my lexicon, and I've really found it useful, obviously. Yeah, thanks, Ben.
Can you develop any more your idea about soft paternalism?
Yeah, I think the other way I call it is sharing the moral burden. And I watched a video about this when I first was I'd transitioned from adult palliative care to pediatric palliative care, and the difficulties of when a parent is stuck in a dual role. There's, as a surrogate decision maker, they're supposed to be doing what they is in the, if they were in their child's shoes, what they would want. But a lot of times parents would say things like, well, if this was me, I wouldn't want them to do it because it's my child. I need to fight for him and we have to do it. And so it's that tension there that I really recognized, that giving a recommendation to a parent rather than giving them, what do you want to do? And, who in their right mind would say, yes, I would like to turn my child's ventilator off, right? When you phrase it that way, would you like to turn your child's ventilator off? And we've seen this. I've seen it in the US. I've seen it here. Whereas a more directive approach saying, we think that soon is the time to gently separate your child from the technology, and make it a recommendation, and then open it to negotiation about time or other things and what the parents' values are. But to start with the directive that this is where we're heading, not what do you want.
Great. Well, thanks very much, Janine. And now,
If I could just make one other comment, I had my hand up, but you might have assumed I hadn't turned it down. And we do have a bit of time. I've thought a lot about this idea of soft paternalism, and I think the word paternalism's got too much baggage around it, particularly in a bioethics setting. And I've been thinking much more in terms of manaakitanga, as being a term which covers what we're doing here, which is that you are caring. And I think your point about vulnerable people, that vulnerable people can't make good choices because they're stressed and anxious and they need care. So I think it's a more interesting discussion to talk about. So what is manaakitanga and how does that apply? Because it doesn't have the baggage of paternalism tied to it.
Yeah. I still find myself getting defensive around paternalism and soft paternalism when I say that. And if I bring it up to medical students, they kind of get all, if I use the word, even with the word soft in front of it, they get their backs up. And so, yeah, I had used sharing the moral burden is how I prefer to think of it. But thanks, Lynn. I hope we do use the
a last comment. The most graphic example I've ever seen of autonomy by a child was a child who'd been in a car accident and had his spinal cord effectively severed at the neck from a fracture. And I was called up to give evidence about allowing a child to die. He was about 8, as a matter of fact. And by the time I got there, the most compelling bit of evidence was that he'd written a list with all his toys on it and the friend he wanted to give them to when he died.
These stories can have profound impact on us for such a long time. Yeah. And to not lose that, it's a tough balance between being defended to keep being able to go back in as the provider, and between carrying that in your heart.
Well, on that somber note, I'm going to our next talk, which is about university redundancies, by Gareth, who'll be speaking next week. So check out our wonderful poster along with all the others on the way out, and look forward to seeing you and others there next week. Let's all thank Janine for wonderful work.